Okay, so my topic is overcoming the coronary calcification with advanced PCI techniques. Well, as we know, the calcium can cause a lot of problem during PCI procedures, such as stent angular expansion, malposition, and sometimes stent dislodgement, just as previous speaker mentioned. So the coronary calcification is one of the leading causes of stent failure. Well, during the procedure, there are several points need to consider for severe calcification. Important thing is the length of the lesion and the tortuosity of the lesion, and we should pay attention to the minimum lumen diameter of the lesion, especially if the lesion can be crossable and uncrossable. If the lesion is crossable, maybe we should use intravascular imaging to guide the procedure. If it's not, well, if the lesion have following factors such as circumferential calcium, calcified nodule, or vessel diameter is less than 3.5, if there are any of the two of these features, maybe we should escalate our PCI strategy to use atherectomy or more advanced PCI techniques. If we choose OCT guidance, we can also measure the depths of calcification. If it's more than 5 millimeter in depth, we should consider atherectomy. And if the lesion cannot be crossable, in that case, we should use active rotational atherectomy strategy to fully prepare the lesion. So next, we'll have some case examples. First one is a mid-aged male patient with typical chest pain. From coronary angiogram, we can see. Sorry. From the angiogram, we can see severe stenosis and diffuse lesion at LED. Especially, we can see the curve, the acute curve of the midterm of LED. It's like a Z shape. So it's hard to, when you have this acute band with severe calcification, all the device is very hard to cross. So before the procedure, we consider to use rotablation, but with the acute angle, rotablation sometimes can cause dissection. So rotablation should be performed with a small burr with carefully, gently manipulation. But well, when we start the procedure, we find the microcatheter cannot cross. Even we exchange to 7 French EBU guiding catheter, the Corsair guiding catheter cannot cross the lesion. So we tried multiple attempts, still not cross. Then we use extension. We try to use a small balloon, smallest balloon the balloon can pass, and we pre-dilate with a 1.25 millimeter balloon with 20 atmosphere. After dilation, the intravascular ultrasound still cannot pass. We exchange to microcatheter, but Corsair still cannot pass. So we want to increase the backup support of the system. So use Godzilla to provide stronger backup. So with the Godzilla 1.7 French micro catheter can finally cross the lesion to the distal, so we could start the rotablation procedure. We used the smallest burr to perform rotablation with multiple attempts, but the ablation burr just cannot pass the lesion because there is acute curve and the severe stenosis. So even multiple morphology of the lesion, the rotablation burr still cannot pass. So then we try to use traditional balloon predilation, use 2O balloon, and it's not fully expanded. Then we use scoring balloon to try to dilate it with repeatedly, and maybe after 7 or 8 times, I don't remember, but just after several times of expansion, the balloon finally fully expand. So we then perform the IVUS for the lesion. We can see actually the calcium is not as that sphere. It's just a calcified nodule protrude to the lumen. And because the vessel is very tortuous with the acute band and the calcified nodule, it become impossible for any of the device. So we can see it's not that sphere calcification. So then we just put 2 stent from for the LAD. It's the final results. So just we move to second case. It's also an LAD stenosis. The patient was first performed angiogram and PCI in a local hospital. They firstly performed PCI for their right coronary artery. Then when they tried to perform PCI for left coronary artery, they find the calcification is where the balloon cannot pass, so they strongly push the guiding catheter, cause dissection of the ostium of left main. So they have to put a stent at the ostium of left main. And then the patient will transfer to our hospital. So because we can see the lesion of LAD was very tight and diffuse lesion and severe calcification, and they also have a stent at the proximal from left main to LAD, and that increased the difficulty of the procedure. But luckily, the right coronary artery is fine, so it provides good cholesterol. So for this time, we use strongest guiding catheter, and even though the microcatheter cannot pass, so we use Guidezilla to increase the bicep support and use small balloon to sequentially dilate the lesion. And after balloon predilation, the microcatheter still cannot pass the lesion. Then we use excimer laser to try to modify the proximal part of the lesion. So we use some multiple times of laser atherectomy, but the laser does not cross the lesion, but we just use it to modify the proximal part of the lesion. And after laser treatment, then we use traditional balloon predilation. And but the balloon still is not can expand fully. So, but luckily this time the microcatheter can pass. So we use microcatheter, exchange the guide wire, and start the rotablation for the patient. So the rotablation is quite went smoothly. So after rotablation, we just use balloon dilation, fully prepare the lesion, and deploy the stent. This is the final angiogram of this case. So the last case is also an LAD lesion with diffuse lesion and severe calcification, but it all of it's also looks similar, but each case has its own characteristics. So this time, because the lesion is crossable, we just start the rotablation procedure first. We use a 1.5 millimeter rota to perform the rotablation. But after the rotablation, we can see the first diagonal branch was missed, the blood was compromised, so the patient have severe chest pain during the procedure. So we have to try quickly wire try to find the first diagonal branch and pre-dilate with a small balloon. So after balloon dilation of first diagonal branch and LAD, we performed the IVUS for the procedure for the patient. From the IVUS, we can see after rotablation, there are some crackles of the calcium. There are circumferential calcium of the lesion, and this is very tight lesion. But luckily, after rotablation, we can see some crackles of the calcium. So it indicates the calcium can be dilated by balloon. So then we use a balloon predilation and put a stent. We think it's very, it should be smoothly and easily finish the case. But as here we can see the stent is not fully expandable. We also performed a kissing inflation of the first diagonal branch because the diagonal branch has very severe stenosis. And after stent implantation from LAD to left main, we perform an IVUS. But here we can see at the proximal of LAD, so here the stent was not fully expanded. The minimum lumen area is only 3.8 millimeter, and it's proximal of LAD, so the result is not acceptable. Then we exchange to use a shockwave balloon to perform a post-stent dilation. And we use like 80 times of shockwave dilation. And finally, it's expandable. Then we performed the IVUS. The IVUS showed the minimum stent lumen, minimum stent area is increased from 3 to more than 5 millimeter square meters, millimeter square. So, so these 3 cases, all of them are LAD lesions with severe calcification and diffuse lesions, but we use a different strategy because because it's different characteristics. So sometimes for severe calcification, it may require a stepwise approach to fully modify the lesion, which multiple advanced techniques such as laser, rotablation, and intravascular lithotripsy in combination, we can have a good result. And tailoring the strategy should be based on lesion characteristics and to have optimal PCI results. Okay, thank you for your attention.